So this was a trial of omega-3 fatty acids, gamma-linolenic acid, antioxidant supplementation in the management of patients with acute lung injury, or what we called omega. Just some brief funding things. This trial was funded by the ARDS network, which is a government-funded network. The module that we used, the supplement that we used, was actually supplied to us by Abbott Nutrition, and they had no input into the study design, the analysis, the interpretation of the results, but they were nice enough to provide the module for us. Many of you know this, some biological plausibility. On your left are the omega-6 fatty acids. When worked on by lipoxygenase and cyclooxygenase, they form 4-series leukotrienes and dianoic prostaglandins, which are pro-inflammatory mediators. And as we all know, ARDS is an inflammatory disease in the lung. On the right side are eicosapentaenoic acid and docosahexaenoic acid, or EPA and DHA. Those are the omega-3 fatty acids that come from fish. And those are thought to make 5-series leukotrienes or trianoic prostaglandins, which there's a little bit of argument, but they're at least less inflammatory and many think anti-inflammatory. In addition, there were 3 previous studies in humans. They all used a continuous omega-3 enteral feed that was commercially available. Each enrolled about 100 patients. You can see them referenced down there in the bottom, Gaddick, Singer, and Pontus Arruda. All 3 of them showed at least some benefit in clinical outcomes, and you can pick which clinical outcome matters to you, but that showed improved oxygenation, less time on the ventilator, less time in an ICU, development of fewer organ failures, and one of them, the Pontus Arruda study, actually showed lower mortality. So using all of that as a precursor, we conducted this study with the hypothesis that omega-3 fatty acid and antioxidant supplementation, as compared to a placebo, would improve clinical outcomes in patients with lung injury by attenuating systemic inflammation. This study was actually a factorial design, 2x2 factorial, on a feeding strategy, an enteral feeding strategy of either early full feeds or early trophic feeds. That study just completed actually this summer. I'm not going to present the results of that study, but I just do this for disclosure. I will present the results of the omega-3 antioxidants in control. Here's your feeding timeline. So you could be ventilated for up to 72 hours before enrollment and have lung injury for up to 48 hours before enrollment, trying to get patients early in their course of lung injury. Once you got enrolled, within 6 hours, you got started on the enteral feeds and your supplement. Your supplement was given every 12 hours until you either were extubated from mechanical ventilation or day 21 of your hospital course. What was in the supplement? This shows you the supplement compared to the control. You'll notice that it's isocaloric. Both have about 2 calories per cc. You'll notice that the control group actually has a higher level of protein and a higher level of carbohydrate, and that was done so that it actually has the same amount of calories. And you'll see that the omega-3 antioxidant group has more fat, largely in the form of EPA and DHA, the omega-3 fatty acids. It also has GLA, which is an omega-6 fatty acid, but is thought to form PGE1 in this environment, which may have some pulmonary vasodilatory effects. In addition, this omega-3 supplement also had antioxidants in it relative to the control. Why were these values chosen for our supplement, our module? These are the amounts in the 3 previous studies that were the daily averages that were administered to the patients in those studies. So we tried to mimic what was given to those patients, but put it in a module that was given twice a day instead of as a continuous feed. Who did we study? We studied patients that had lung injury by the American European Consensus Conference guidelines, PDF ratio less than 300, infiltrates not consistent with, or consistent with pulmonary edema, but without evidence of left-sided heart failure, and then you had to be mechanically ventilated in order to be in this study. In addition, your physician had to plan on giving you some enteral feeds so that we could administer enteral supplement. Our endpoints were ventilator-free days to day 28. Most of you know that a ventilator-free day is a day that you're both alive and off of mechanical ventilation, so it's a combined endpoint. Our secondary endpoints were mortality prior to hospital discharge to day 60, ICU-free days, organ failure-free days, and then we have measures of serum and urine inflammatory biomarkers that I actually won't show you today. But care was standardized in a number of ways. All patients received a lung protective ventilation strategy. All patients received conservative fluid management strategy. The glucose control was not a standard protocol across the network, but every site had a protocol that controlled glucose to at least 150. And for those of you that don't do the European or the American units, divide that by 18 to get yours. And GI intolerances were both defined specifically for this trial, and the actions for those GI intolerances were also defined for the bedside nurse. Here's the results. Similar to the last one, these are actually being presented online at JAMA as we speak. Here is the consort diagram. You can see in our 44 hospitals, 12 academic centers, there were almost 2,800 patients screened. The biggest exclusion here was about a fifth of the patients had severe chronic lung disease. Time window was a big exclusion, either more than 48 hours of lung injury or more than 72 hours of being on the ventilator. There was an inability to obtain consent in a large number of patients. Many patients were thought to probably pass away from their underlying disease and not from their ARDS. There's some in vitro data, about increased hemorrhage risk with omega-3 fatty acids, so we included anybody that had an increased risk of hemorrhage. And then you can read the lower ones beyond that. Of those, 272 were randomized. Now, if you remember back to my factorial design, you say, I thought this study was going to enroll 1,000 patients. It was planned to enroll 1,000 patients. This was the first DSMB look, and at this point, they stopped the study for futility. And I'll show you the results why. Of those 272, 143 received the omega-3 supplement. Actually, were randomized to receive it. One didn't. And 129 received the control supplement, which was a commercially available supplement. They were all analyzed in the arm that they were randomized to. Baseline demographics, you can see on average they're mid-50 years old. They're about half female and male, largely a white population. We're a largely medical ICU group, so you can see that most of these factors that cause lung injury, predisposing factors, are medical. Pneumonia in over half of the patients, severe sepsis in another fifth, and then aspiration, a little bit of trauma, and some other. But you can see in that bottom line, the vast majority of these patients come from medical ICU. They're a fairly sick population. Apache 3 scores above 90. Over half of them were on pressors at the time of enrollment. You can see their pre-study fluid intake is about 5 liters in the 24 hours prior to enrollment. They have a little bit of renal dysfunction on admission, and you can see glucose and albumin levels there. What about their respiratory parameters? They're pretty similar between groups, with the exception that minute ventilation was slightly higher in the omega group, and the P to F ratio is also slightly lower in the omega group. This is a little bit of a complicated slide. It's figure 2 from the JAMA manuscript. This is actually in the first 60 patients we measured plasma EPA and arachidonic acid levels in order to assure that we were actually getting absorption and getting some systemic effect. You can see from this that at baseline, EPA levels are similar in the circles, which is the omega-3 group. The triangles is the control group. These lines are actually the means, and the circle is each patient. Those values go up 8-fold in the omega-3 group on day 3 and continue to be 8-fold higher on day 6 and day 12. Some of you may like ratios. If you look at ratios, you see the same effect, omega-3 to omega-6 ratio. How well was this tolerated? There were a few GI intolerances, the biggest one being diarrhea. Even in our control group, that occurred in a quarter of the patients, and about a third of the omega-3 patients. Then there was also a statistically significant difference of vomiting, although it was pretty low, less than 5% in both groups. Unfortunately, all 3 of the previous studies showed an improvement in P to F. We were unable to replicate that and saw no difference in the P to F ratio across the first 7 days. Remember, this top one, ventilator-free days, is actually our primary endpoint. And you can actually see that there is a difference in the ventilator-free days, but it's actually bigger for the control group. More ventilator-free days is actually better. So the control group had 3.2 more ventilator-free days, more days alive and off the ventilator than the omega group. And as is almost always happens, that correlated into more ICU-free days too. What about mortality? You can see there actually was about a 10% absolute difference in mortality, 26.6% in the omega group, 16.3% in the control group. When you try and adjust for some baseline variables, you can see that those get a little closer together, but don't change a whole lot. And for comparison, the previous study that we had conducted, which was the fat conservative arm, the mortality was about 25% in that arm. So regardless of omega-3s, our mortality is actually improving as we do these studies. If you like Kaplan-Meier curves, here's a survival analysis, control versus omega. On the bottom here is coming off the ventilator with assisted breathing. We call this our funnel plot, and it's informative because patients above the top 2 lines are deceased. Patients between your lines are alive, but still on the ventilator. and patients below your lines are alive and off of the ventilator. Other organ failure-free days, there's no difference in renal hepatic coagulation. There were more CNS failure-free days and cardiovascular failure-free days in the control group. Quick summary of main outcomes: death at 60 days, 26.6% in the omega, 16.3% in the control, 3.2 more ventilator-free days in the control group, which led to 2.7 more ICU-free days in the control group. So the conclusion was that omega-3 fatty acid and antioxidant supplementation, twice daily at interval feeds, does not improve outcomes in patients with lung injury and in fact may be harmful.